James Ashcroft, my right, and Inês Macedo. Those are our speakers now. James is a senior medical student in the University of Manchester, and he will talk about assessing the effects of transcranial direct current stimulation upon attention in Lewy body dementia, a crossover trial. He will contextualize his presentation. Thank you, James.
Thank you. So, I'm a medical student in the UK at Manchester, and I undertook a Masters of Research last year investigating transcranial direct current stimulation. And I did this in collaboration with the Institute of Neurosciences in Kolkata in India and at Newcastle University, which is up north in the UK. So, does transcranial direct current stimulation improve attentional function in Lewy body dementia? I'm going to try and cover Lewy body dementia and transcranial direct current stimulation, or TDCS, and then what I studied and what I found. I'd like to start with a picture of this man. Does everybody know who he is? Yeah, so this is Robin Williams, who was a very famous comedian, who 2 years ago tragically committed suicide. And it was found on autopsy that actually he was suffering from Lewy body dementia, and that contributed to his suicide. So it's a very important problem that we do need to deal with. Now, what is Lewy body dementia? Well, it's not known why, but there's a build-up of Lewy bodies, which are neurotoxic and alpha-synuclein proteins, which cause a dementia picture. But this dementia is different from other dementias, such as Alzheimer's dementia, as memory loss is much less prominent, whilst other symptoms such as movement disorders, sleep disorders, and hallucinations are much more prominent. And at the moment, the mainstay of treatment is cholinesterase inhibitors, which have limited efficacy. So new therapy is needed for Lewy body dementia, but for this study we just focused on attentional dysfunction. So I was sent to the Institute of Neurosciences in Kolkata, and I went over with this direct current stimulation. So to tell you a little bit about this, I thought I'd talk about the history of it. And I begin with Luigi Giovanni, who discovered that applying a direct current to a dead frog's legs caused them to twitch. And that's where it all started, and that was in 1780. And from there, his nephew, Giovanni Aldini, applied a direct current to a deceased criminal in London, which then caused his muscles to twitch and his eyes to open and his body to contort. And these were the first human experiments using direct current and quite a high density of direct current. And there was someone in the audience of this experiment, and that was Mary Shelley, who then authored the story of Frankenstein. So that's the inspiration behind Frankenstein. But actually the same man, Aldini, then went on to apply direct current to patients with depression and found that it improved their mood. So this was the first application of direct current. However, nowadays we use a much lower amount of electricity of current, and there's been quite a few different applications for TDCS, but the one that we're focusing on today is attention. So, what we did was use 2 electrodes, an anode placed on the scalp overlying the cortex of the brain, and a cathode which can be placed anywhere else in the body. And this creates a weak direct current which excites the cortex underneath the anode. Now this has an immediate effect of increasing neuronal firing, and it has an after effect of long-term potentiation and synaptic plasticity. And we decided to stimulate the dorsolateral prefrontal cortex with the anode. Now, the DLPFC, or the dorsolateral prefrontal cortex, has improved working memory and attention in healthy individuals, And it's also improved attention and healthy and working memory in Parkinson's disease patients that also have these Lewy bodies. So that's why we chose to stimulate the DLPFC. And we just used a single session, and we aimed to induce that immediate effect of increased neuronal firing. And we hypothesized that a single session of TDCS would improve attention in our Lewy body dementia patients. So, we recruited 23 participants from the Institute of Neurosciences in Kolkata, and we did some baseline assessments to confirm their diagnosis of Lewy body dementia and to assess their movement disorder, and assess their cognition, and to overall assess their suitability for the study. We then randomized the patients and either gave a sham, a placebo stimulation session, or an active stimulation session. Following the stimulation, we then performed some attentional tasks on a laptop system and then sent them away for 3 days. And that was to let all the effects of the stimulation dissipate and wear off. After 3 days, we brought them back and gave them the opposite of the sham or active stimulation, and then performed the same tasks and analysed the results. As for the TDCS, we gave a 20-minute session of stimulation at 0.0 milliamps per centimetre squared, which is the highest density used in current literature. And we used a battery-powered stimulator. And this stimulator was code programmed, so I was completely blinded to the study. And when we applied the sham stimulation, it gave a very brief blip of electrical stimulation to try and replicate any side effects, so the patient was also blinded to the study. The anode was placed over the left DLPFC using the International 10-20 system for EEG, and the cathode was placed over the right deltoid muscle. For the attention tasks, we had a simple reaction time task where a cross appeared on the screen. The participant had to press a button every time the cross appeared. A choice reaction time task where an arrow appeared on the screen and the participant had to press either a left or right button depending on which way the arrow pointed. A digit vigilance task where a number cycled between 0 to 9 in the middle of the screen, and the participant had to press the button every time the number landed on 9. And an attentional network task which had 4 arrows, and the participant had to press left or right depending on which way the majority of the arrows pointed. Now these arrows could point all in the same direction, which was a congregant trial. An easy incongruent trial where 3 of the arrows pointed in the same direction, all next to each other. Or a hard incongruent trial where 3 arrows pointed in the same way, but only 2 were right next to each other. So this is a picture of the setup, and what I was trying to demonstrate here is that it's very simple to set up. Simply electrodes placed on the scalp and on the muscle, which can be incorporated into a cap. And it's also quite safe and also very cheap, so it's perfect for those that have no access to regular medical care, or for those that can't afford regular medical care in some parts of the world. And there we have our laptop as well, and the buttons that the participants pressed. Now I thought I would put this picture, and this is the Ganges, and I find it very calming, this picture, and the next slide is graphs and p-values, so I thought it would be nice to have a nice calming picture and to just summarize. So we have these Lewy body dementia patients, we've stimulated them with either active and sham stimulation, and now we're going to compare the results we had of the tasks, the attentional tasks, active, after active, and after placebo. Now first we're going to look at a simple reaction with the cross, the choice with the arrows, and the digit vigilance with the 9. And when you compare active to sham stimulation, there's absolutely no benefit in giving active stimulation. So we thought this is the number of correct responses, and we thought maybe the participants were having the same number of correct responses. They were just getting those responses faster with the active stimulation. So next we looked at the correct response reaction time. and the reaction time also showed no difference. So participants with active stimulation had no increased accuracy and no increased reaction time with stimulation. And finally, for the ANT, attentional network task, there was no difference in any of the trials. So in conclusion, a single session of TDCS didn't improve attention in Lewy body dementia patients. However, it did show that it's very simple, safe and cheap. There was no adverse side effects recorded apart from slight irritation of the scalp and the skin under the electrode. No participants dropped out after receiving the stimulation. So there's a few points to discuss with this study. The first is the role of the DLPFC. So studies are finding that when you try to compare this study with other studies, you find that a lot of studies are using different tasks, so it's quite difficult. And a lot of other studies have found much more convincing results when studying working memory and not specifically attention. And that calls into question what the exact role of the DLPFC is and whether it has more indication in working memory, which may then improve attention, but to a weaker effect compared to actually being directly implicated in attention. And also, that's another point. It's quite difficult to compare this study when there is a publication bias present. So papers that don't find positive results are almost 5 times less likely to be published. So that's why it may be difficult to find other studies saying that there is no effect of TDCS. However, the role of the DLPFC is important, and there are current studies that are using MRI and other imaging procedures to try and fully identify where is best to stimulate with TDCS. And there are also developments in TDCS itself. This is quite a new high-definition stimulation where the middle electrode is the anode giving the excitation of the cortex, and that's surrounded by cathodes which depress the rest of the cortex. You have a very specific point of excitation. The other point which I want to discuss is the fact that we tested only the immediate effects of stimulation. And we actually tested the residual effects as we stimulated the patients and then performed the attentional tasks. And our tasks did take up to 60 minutes in some patients, the more severe patients. And in that time, it may well be that the effects dissipated and wore off. And some of the studies that have had positive results, studying attention and TDCS, have found those positive results by stimulating at the same time as performing the tasks. So this is a future direction for the study, to find positive results. However, a much more important direction, in my opinion, goes back to this slide. So we tested those immediate effects that increased the neuronal firing. However, the after effects of long-term potentiation and synaptic plasticity and changing the microstructure of the cortex is much more likely to give a more significant result, and in recent studies has been found to give great results in movement disorders that have been stimulated every day of a week for 4 weeks, and they have found results which persist at 6 months after stimulation. So my number one recommendation for furthering TDCS is to give repeated sessions and to induce that synaptic plasticity to create long-lasting results. So I've talked about how TDCS has the potential to increase attention, and you can purchase TDCS legally from any website, Amazon, and some students use it to study. And it may help you to get through your patient lists and your prescriptions. It may keep you up at night and keep you focused. But before you go out and try and rush into TDCS, I thought I would show you this recent news article that in a recent study in healthy individuals, TDCS actually was found to lower the IQ of the participants. So there is still a lot of evidence which needs to be gathered, a lot of performers which are needed in TDCS, but it does have the potential to become a therapy which is affordable and can reach those patients that desperately need the help. So thank you. I'd like to thank all my supervisors and the staff in India and all the participants and their carers involved too. Thank you.
Okay, thank you, James. It was a very inspiring. I don't know, but it challenges this presentation. I don't know if someone wants to put some question right now about this presentation. Okay, so maybe we'll have the questions for the final of this table. And Inês, you want to start now? Okay, thank you. So Inês, she's a resident in psychiatry in the Centro Hospitalar de Lisboa Ocidental, and she's a member also of the Portuguese Society for Existential Psychotherapy. Thank you, Inês.
Thank you. Hello, everyone. So, besides being a resident in psychiatry, I also collaborate with a program called Cosmic Care that provides psychological help in people who had taken like recreational drugs. So I got in touch with this subject in the way of working with these people. So that's why I was interested in this theme, and I contacted with people who had taken these kind of drugs and that reported sometime later like kinds of changing in their behavior towards life. They had different attitudes towards the drug consume. So I started to ask myself whether these kinds of substances could do anything to their mental health or their behavior, generally speaking. So I started studying a little bit about these subjects, and I arrived here. So the outline of my presentation will be this. I'll make an overview on psychedelic therapy, present briefly the earlier and recent concepts on the therapeutic uses of psychedelic substances. I'll present briefly the recent evidence for the therapeutic and transformative efficacy, and present possible mechanisms of therapeutic action of these substances. So, first of all, I would like to introduce this by saying that psychedelic substances may be the oldest psychoactive substances known by men. They are used by men for centuries or even millennia. These statues are the mushroom heads found in Tanzania. They were found similar statues in South America that relate to the use of psilocybin mushroom in ancestral medical and religious rituals. Other cultures that use psychedelic substances are, for example, the Amazonian tribes in Peru, in Brazil. They still use these days a mixture of plants called ayahuasca that maybe some of you have already heard about, that has as an active compound the DMT, dimethyltryptamine, that is also considered a psychedelic substance. Peyote cactus is widely used by the North American native cultures, and is also known to have the mescaline, that is the psychedelic active compound in it. So these substances are known for a long time ago, and they are still used in some small communities, as some religious churches in Brazil, for example, they are used in religious rituals. Well, around the 50s and the 60s, after the discovery of LSD by Alfred Hoffman in 1943, the discovery of the molecule for other medical purposes, he accidentally took this substance, and we discovered the psychoactive properties of it. So he was in touch with other scientists and psychiatrists, and there was a huge interest on the properties, the psychoactive properties of this substance, and some psychoanalysts particularly, started using this substance in their psychoanalysis with their patients. They started giving LSD to the patients to be more in touch with them, to enhance the empathy, and to, enhance the efficacy of the therapeutical process, the analytical process, sorry. Other scientists started using these kinds of substances, particularly LSD, to understand. They found that the effects, the psycho effects, were very similar to the one that psychotic patients had. It provoked perceptual and thought changes that were very similar to the ones found in schizophrenia or other psychotic patients. So some of them started using them to understand psychosis, and in some extent doing experiments trying to get benefit from these substances in treatment of other illnesses, as like alcohol dependence or anxiety related to terminally ill patients. The results were promising at that age, but the studies lacked lots of standard quality methods that nowadays are very important. They were heterogeneous, they were done with no control groups or placebo or any other of these scientific methods that we know nowadays. So their validity is not that, we cannot rely on it. And there was other thing that this molecule LSD got out of this clinical environment and was used largely by some groups of counterculture people, like associated with the hippie movement and with the political and socially like rebel movements, and they were not behaving like decently. So this was considered a drug and was completely put out of experiments, or the investigation stopped at that time. Something interesting about the LSD, who touched a little bit the progress of psychiatry, was that 10 years later, after the discovery of LSD, serotonin was identified and discovered, and it was found that they shared this molecular structure, these two rings, these tryptamine rings. So it was postulated that serotonin could have some implication in brain function and eventually in psychosis. So this was also an importance of this discovery. So in that days of the psychoanalytic processes using these substances, they were used small, low doses of LSD, for example, or of other psychedelic substances, and they were used in the process of an analytical process. There were numerous sessions. The analysts thought that this substance could activate or deepen the psychoanalytical process, and there was a reality comparison, a work between the therapist and the client, for example, and an attempt to adapt the experience to the everyday life. Well, the indications were the same as for the psychotherapy that we know nowadays, for example, neurosis or psychosomatic diseases. And on the other hand, when we are talking about psychedelic therapy, that is the therapy that is now starting to be studied again, we are talking about a different kind of use of these substances. They are used in high doses, almost 10 times or 2 times the low doses that psycholytic therapy used. They induce cosmic, mystic experiences of oneness and ecstatic joy, and there are no foundations in clinical psychological theories. The aim of this kind of work is to induce overwhelming experiences that are not included in any therapeutic procedure or process as the other that was done in the 50s did. The indications that are defended are alcoholism and drug addiction, anxiety and depression in terminal phases of somatic illness, for example. The first one, the psycholytic therapy, was the uses of these substances were supposed to melt or open the soul of the patients, as the literature reveals. By contrast, this psychedelic therapy, the aim is to manifest the mind and some processes that are much more related to the subjective experience of this cosmic and mystical connectedness to the cosmos, as the literature says. So, what is this psychedelic experience? Is an altered state of consciousness with intense thought and perceptual changes, and is extremely dependent on drug, set and setting. What is this set and setting? The set of the mind of the person who takes the substance, or for example, there are variables like traits of personality. They are much more prone to this effect, to this experience of extreme well-being and connectedness. And the setting is the environment, the exterior environment of the person. For example, if we study the experience of a person who is in a friendly environment, for example, in a couch with someone friendly around, comparing to, for example, someone who enters an fMRI machine in a very clean laboratory with non-friendly people, the experience is completely different, and the probability to have this connectedness and openness and this well-being experience is less probable. So there is also a sense of insightfulness, understanding and new perspectives related by the patients, and this experience shares characteristics with non-drug related mystical experiences, like religious ones, for example. Nowadays, the studies are much more scientifically accepted, and it's important to think about this because from my personal experience at the hospital, for example, we have seen much and more frequently people who have taken these kinds of substances, and many times in the context of these religious rituals that came out, that spread all over, and that are not anymore restricted to the Amazon, for example. Nowadays we have here in Europe, in Portugal, people taking ayahuasca, this beverage that puts people in contact with God, or there are lots of different forms of experiencing it. We have 3 more studies, one on tobacco dependence. This study included 15 subjects, all included in a 15-week CBT, cognitive behavioral therapy, and in the middle, there were 3 times they were administered psilocybin, and there were very good results. 80% of the subjects quit smoking for the 6 months, the 6 months after the study finished. Another study on alcohol dependence with 10 people. And here we had also a psychosocial intervention, and at weeks 1, 3, and 7, I think they used psilocybin also. The results were very interesting too. And at last we have this study with ayahuasca given in people with major depressive disorder, and they showed a reduction in the Hamilton score, 2 scores. And 21 days after the last administration, the only one. So, looking at this, we can see, wow, we have good results, but we will talk about this later. So, the possible mechanisms of action from the animal model studies and from the things that have been done until the present moment show that the core psychedelic effects are transmitted via this serotoninergic receptor 5-HT2A. On the other side, the therapeutic effects may come from the agonistic action on these receptors and others, 5-HT1A, 2A, and 2C, from the modulation of glutamatergic transmission induced by this agonism of 5-HT2A, and by the interaction with other transmitter systems. Well, the truth is that very little information we have about these kind of molecules because they are not studied from a long time ago. On the other hand, there are groups of investigators, especially in North America, that are trying to understand a little bit better, and that Carhart Harris is an investigator that has dedicated lots of time studying these, and they found that these kinds of substances reduce cerebral blood flow in some specific regions, especially this default mode network that was touched just in the previous presentation. That is this network, this neural network, constituted, for example, for this postural cingulate cortex and the medial prefrontal cortex. So what is what was found is that this kind, psilocybin is the specific substance that has been used in this study, that it decreases the blood flow in these regions. Well, the default mode network is responsible for this introspective kind of thinking, is activated when people are not cognitively active, are, for example, are conscious, but thinking or self-reflexive or introspective. So this is thought to be decreased, and well, the investigator Carhart Harris postulated this hypothesis of the entropic brain under the psychedelic substances, because when the default mode network is with decreased activity, there are much more connections that are activated, and there is, this is the theory that is behind. And now, the questions that arise me were a little bit more or less these ones. We have seen a little bit of this pharmacological, neurological effects, but I have said before that these experiences and the effects of these substances are extremely different, even in the same person, from one moment to another, and the effects are that are described are extremely subjective and very difficult to analyze. People sometimes have this connectedness with the universe, or the other feel the total disintegration of the self, of the self, and these subjective experiences are thought to be crucial in the changing of behavior, or the changing of the symptoms. So how can we ever understand? Does every subjective experience has a neural correlate? How can we think about this? Well, I could not answer this question. And what is the role of psychotherapy? How can we understand which is the role of the drug, the role of the therapy, the role of, we have seen in the studies I presented that some of them use psychotherapy in the middle of the session with the drug. Some of the others did not include psychotherapy. Others included motivational interviews. So, I think that the question remains, but some authors, the question in the beginning remains, and some authors have, or there are a general consensus that these psychedelic substances can facilitate or intensify ongoing therapeutic processes but not replace them. That in all major approaches of psychedelic-assisted psychotherapy, set and setting are of great significance. So the personality, for example, of the subject is extremely important and can change the result, the outcome. And psychedelics can work as catalysts or triggers and are administered only one or a few occasions to facilitate this mystical or peak experience with long-lasting benefits, well, that someone say. And it seems to be consensual that psychotherapy and pharmacology can act as a tandem strategy. Well, one and another together to some result. Well, the safety of these substances, I think, is a subject that we should address to, because it's impressive. I don't know if any of you have seen people under these kind of substances, and well, it can be impressive because perception becomes completely altered, and so a psychotic kind of behavior, or well, it was. I would like to say that, well, the studies that I presented before, they say that it was safe to administer in controlled environments, in opposition to the administration or the self-administration of these kinds of substances in recreational environments. Well, the judgment of reality is completely disturbed, and there are sometimes accidents involving physical integrity. It's said that it's known that these substances do not lead to addiction or dependence, and they are not considered to be reinforcing. There are no significant associations with mental health outcomes, and from a physiological point of view, they are safe drugs, safer than other substances used, for example, in recreational environments. Well, the thing that I concluded here is that more evidence is required, and we cannot take any conclusions because the actual studies are small in number, use small samples. We have seen that the biggest sample was with 12 individuals, and I think that we cannot take conclusions on 12 individuals, and there are highly heterogeneity between the studies. Some of them do not include placebo or control group, for example, and the most difficult thing is to disentangle the effect of the placebo effect of the substance, the effect of the drug itself, the effect of the psychological intervention, if it has done or not. So I think that we cannot conclude, but this is a field of investigation that I think that deserves attention, and well, that's it. Thank you. Questions?